most people would rather be at home than in hospital. So wherever possible, we would try to deliver the care in the person's own home.
And you mentioned about treating the symptoms and treating the person as an individual rather than the disease itself.
A palliative care approach doesn't just look at the right drug to put that person on for their pain. It looks at how their pain affects all aspects of their life.
What does it mean to deliver holistic care to an individual? Hello, I'm Hannah and welcome back to the Life and Loss podcast, where we discuss difficult topics including living with life-limiting illnesses, dying, death and bereavement. Today I'm joined by Dr. Amy, lead consultant at Forest Holme Hospice. Welcome, Amy.
Hi there, thank you very much for inviting me today.
And in this episode we will explore the role of palliative care in enhancing the quality of life. So Amy, for those that don't know, what exactly is palliative care?
Well, that's a brilliant place to start. And actually the general public, but also professionals have problems with the terms palliative care because there's a lot of misunderstanding around them. So the word palliative actually has its origins in the Latin name palliare, and that means cloak. So I like to imagine it as like a cloak or a comfort blanket around somebody, and something that's shielding the people that we look after from the harms that the illness can cause. In palliative care, we like to put the person who is experiencing the illness and the symptoms at the centre of everything that we do. Often at medical school, and as healthcare professionals, we're taught to focus on the illness itself rather than how it's affecting the patient. So palliative care is a whole different approach where we start with the patient and think about how their life is affected by the illness that they have and how we can enhance that quality of life. So we're not looking necessarily to extend life, although later I can explain that sometimes that does happen, but we're trying to make life better, and we're usually very successful in doing that. Just to come back to the misconceptions about palliative care, which I touched on at the beginning, often people are worried that referral to palliative care means that time is very short. So that's a myth. It doesn't necessarily mean that time is very short. Often people think that once people are referred to palliative care that nothing else can be done. And again, that's a myth. There's so much more that we can do. And we work alongside other specialists. So being referred to palliative care is an extra. It doesn't mean that you've got less opportunity at living.
And when might it be appropriate to sort of introduce palliative care into someone's life?
So palliative care is appropriate actually at all stages of someone's illness. So from diagnosis. For example, the other day I was asked to see a lady who had a problem in her tummy. It wasn't a cancerous illness, it was a blockage, a completely benign blockage. She'd been in hospital for a really long time, some months. She had some other health problems, which meant that she was never quite well enough for an operation. And as a palliative care doctor, I was asked to go along just to help support the decision-making process about whether she would have this operation or not. And we actually all agreed with the patient herself and with the family that going ahead with the operation was the right thing to do. She's had the operation and we don't need to be involved anymore. So yeah, palliative care very much dips in and out throughout somebody's illness, and depending on how they are and how their quality of life is at that time, we tend to be more or less involved.
And you mentioned there that it was non-cancerous. What sort of conditions would people have where they would be referred to for palliative care?
Yeah, so you're right. A lot of the work that we do isn't in cancer care, although that's another misconception. People think that palliative care is normally given to people with cancer. But if we go back to what palliative care does, and that we treat the symptoms of people's illness, often people who haven't got cancer but who have got other conditions such as heart failure, such as neurological diseases like motor neurone disease, they're often living for a long time very symptomatically, and healthcare professionals can just focus on the disease rather than on the symptoms and quality of life. So palliative care is very appropriate for all chronic waxing and waning or incurable diseases to help people live better and for longer.
Okay, and you mentioned that it is sort of provided alongside medical care. How do those two interact?
So it's really important that we work with other specialties. So it isn't a matter of, for example, if we go back to if somebody has cancer, the oncologists give a lot of chemotherapy and radiotherapy and then say, we can't give any more chemotherapy and radiotherapy, we'll stop the oncology and we'll start palliative care. Instead, it's very much of an approach that we work with the other specialists. A really good example of that is a motor neurone disease. So people who have motor neurone disease usually meet a palliative care team right at the start. So they'll usually attend a clinic in which palliative care are present, and they'll also see a neurologist who is an expert in the control of the motor neurone disease with some specialist medication. There's often a gastroenterologist who might look at the feeding problems that can be associated with motor neurone disease. And then respiratory doctors can be involved as well, because sometimes there's some breathing problems associated with a weakness with motor neurone disease. So it's really crucial that we all work together to enable that person to live better with the symptoms of their illness.
I hope that you are finding this episode useful. Perhaps you have a question you'd like to ask. You can do this by commenting below. Your input shapes the conversations we have and the topics that we explore. So don't hesitate to reach out and let us know what you'd like to hear more of. And I think you touched on myths already. One of them is that palliative care is just delivered within the walls of a hospice. Can you explain other settings where someone might receive palliative care?
Of course, yeah. So palliative care isn't only delivered by doctors, as you know. We're very much part of what we call a multidisciplinary team, which means that we work with all kinds of healthcare professionals, so nurses, therapists, volunteers, social workers, domiciliary workers. We provide complementary therapy. We have a big team of professionals who can help support the person, and they can deliver the care that the person needs where that person wants to be. We know that most people would rather be at home than in hospital, so wherever possible we would try to deliver the care in the person's own home. At Forest Holme, where we work, we're really lucky to have an integrated team, and by integrated I mean that our offices are based in Forest Holme, but we have the community team which are based there, and the hospital team which are based there and in reach into the hospital, and obviously that we have the inpatient hospice beds. But we were also integrated really closely with the people who provide palliative care, but do it as part of another job, for example, general practitioners or district nurses. So again, it's that teamwork and coordination of the care which enables us to provide palliative care wherever a person wants to have it.
And again, you mentioned about treating the symptoms and treating the person as an individual rather than the disease itself. Hospices are often cited as being holistic in style of care. What does it mean to deliver holistic care to an individual?
So holistic care, again, means putting the patient right in the centre of everything we do. And rather than just looking at one aspect of somebody's life or somebody's illness, you really try to think of all the factors that might be influencing the situation that they're in. So to give an example, I met a lady a few months ago who was a young lady who was referred to me with some pain. She has cancer in her bones. And so a palliative care approach doesn't just look at the right drug to put that person on for their pain. It looks at how their pain affects all aspects of their life, takes into account, for example, their family. It looks at how they're coping with the pain emotionally, psychologically, what their fears are for the future. This lady was really scared and understandably sad about leaving her family when she died. So that was a big part of what we thought about when we were treating her pain. I also referred her to our complementary therapy team to help try and relax her and help her with that aspect. So yeah, it's taking a step back and looking at everything rather than just focusing on one aspect. And by doing that, we often find that we can, by small changes to lots of different things, we can make a real difference.
Thank you. And what do you think excellent palliative care looks like? So if you could have the perfect case, do you have any real life examples?
One thing I would say is we're always learning, and I definitely don't think that we always get it right, and it's really important to reflect on what we do all the time. But I'm really proud of the work we do and the team that I work in, and I could give you many examples, but one example that does just come to mind is a gentleman that we were asked to support a couple of years ago, and he was living with a learning disability. He was in his early 40s, and he was diagnosed with a cancer that was affecting his ear, so it's called a head and neck cancer. And it was causing him a lot of pain, and that was making him really confused and changing the way that he was interacting with those around him and his behaviour. He was cared for in a very loving environment by carers who'd known him for years and years, and he had elderly parents who were very involved and devoted to him as well. But because he was bewildered and didn't understand what was happening, it was completely inappropriate to kind of scoop him up out of that environment and, for example, bring him into the hospice or into the hospital. So we were able, through really careful coordination of his care and communication with everybody who was involved, we were able to keep him at home with the right medicines and keep him calm in the environment that he wanted to be in. And he did die a few weeks later, listening to the music that he loved with the people that he knew. And I think it was an example of a really well-planned and coordinated end of life, which ultimately was acceptable, although very sad for his family and those who loved him.
Thank you. And if anyone listening to this podcast today would like any additional support or help, where do you recommend they go? So
I can't do these podcasts without just referencing another palliative care consultant whose name is Catherine Mannix, and she has written and done some TED Talks, and she's also quite active on Twitter. But she talks so well about her experiences of being a palliative care doctor, and I've learnt a lot from listening to her. She's written in particular an excellent book called With the End in Mind. There's lots of information on national charity websites such as the Macmillan website, which I would recommend people access. And they also produce patient and patient information leaflets as well.
Okay, thank you so much, Amy. And thank you everyone for listening today. You've been listening to the Life and Loss podcast by Forest Holme Hospice Charity. If you'd like more information on our work, please visit our website, which is www.foresthomehospice.org.uk. Thank you. If you found this episode useful, click the subscribe button. Share this episode with a friend or a loved one, and don't forget to give us a like and share your thoughts in the comments. Your support means so much.